Welcome everyone, my name's Deb Shellshear. I'm a paediatric emergency physician at the Queensland Children's Hospital Lady Salento in Brisbane. Now before we start, I expect this to be quite an intimate little panel discussion, so I want everyone to come forward, commit to our session, no escaping out the back doors, I can watch you, and so we can actually talk in a more intimate group. So if everyone can come forward, back rows, come forward, we've got lots of space. Move it on up, move it on up. Thank you, particularly you. Just because you're a radiologist doesn't mean you can't gain something from this. Lots of seats at the front. If anyone's looking for seats, let me help me pick you out. All right, so welcome to our panel discussion. We're looking today at the story of medicine as seen through the eyes of veteran paediatricians who I've been lucky enough to get, not him, I've been lucky enough to have say yes to coming and appearing on my panel. So what I'd like to do first of all is talk about who we have on our panel and then we'll get into the salacious gossip of their history. At any point in time, if anyone has questions, please feel free to put your hand up. I'm happy to take questions from the floor. I'll just have to repeat them for the video, or you may use the mic, but it's a bit far back, so I'm happy just to take it as we go. So, this is our panel today. We have Ian Shell Shear, Julie McInerney, Lawrence Budd, and Annie Milden. And just going through who we have. So this photo up here is of a youthful Larry Budd. So Larry's a paediatrician who hails from Coff's Harbour. He started practicing there when I was 1 year of age. And he has enjoyed such things as 1 on 2 on call for 27 years and watching the annual whale migration. He has extensive experience in rural medicine, and this is actually a photo from 1975 when he was at the RFDS base at Broken Hill. And as you can see, not a single computer in sight there. Well, everything's got gizmos on there. I don't know how that works. Our next person, as she self-proclaimed, is channeling Lady Di. Quite successfully, I must admit, is Annie Milden. Now, Annie has actually been awarded an Order of Australia Medal in 2011 for services to paediatric. She has almost single-handedly set up the Patient Safety and Quality Brief and has become specialised in that area, works at Royal Children's Hospital and Monash, and has huge amounts of experience. Next we have Dr. Julie McInerney, who I had the pleasure of training with back at the now demolished Royal Children's Hospital in Brisbane. She's a paediatric intensivist, and at the time she was the director of intensive care and a director of training for the college. And she was always the person that you went to for exams because she would give you excellent feedback, but you made sure it was early in your preparation because otherwise it would destroy you come the end. She is still, as intensivist, works on APLS and for Operation Smile as well, so she's a very busy woman. And last but not least, a man who shares both my surname, physical characteristics, and hopefully sense of humour, is Dr. Ian Shell Shear. So he's a paediatrician who also comes with extensive rural experience and a heavy behavioural medical background, although if you look at his kindergarten report, did not make a promising start to life. As you can see, he was aggressive and rough to other children, tended to take reaction to feedback as being sulky and tearful, really. The previous executive director of medical services tells me that when he was in medical school, he was known to roll Maltesers down the aisle of the lecture theatre. I find that hard to believe. I'm pretty sure Maltesers went around back then. So our panel today is, excuse that photo, I'm not quite sure how that got in there. Our photo I'd like to kick off today is going to discuss that first pivotal, insightful moment in medicine, that aha, the light bulb moment where you suddenly make a clever diagnosis. You realise what field you want to go into, or your management is just key to what happened to the patient. So I'd like to open this up to our panel and get their recollection of when this has occurred for them. Larry.
There you
Shoot. You can sit down, Larry. No need to
go.
stand up. We're
Thank you.
intimate.
Yeah, thank you. Being asked to be part of this panel was a bit challenging, a bit threatening, really, to realise that somehow I'd got to an age where people actually viewed me as being something other than a junior registrar. One of the opening experiences I had when I commenced my practice in Coffs Harbour in 1981, fresh off the training mill, full of enthusiasm and knowledge and everything else. And I commenced the practice in Coffs Harbour as the first resident paediatrician, so I was there by myself, no junior staff, nothing, no facilities, no nursing staff experience in looking after children. And sure enough, in the first day or two, I was asked to get involved with the infant with respiratory distress syndrome, and full of confidence, I walked in and assessed this child and could see that the child had respiratory distress and asked for a blood sugar. And I got a blank look, and they said, "And how do I do that?" And I said, "Well, you must have some dextra sticks." And I don't know whether you people know about dextra sticks, but they're glucose strips, and they were colorimetric, so you put a drop of blood on them and you looked at them and you had to guess at what the glucose concentration was by the colour change. And the lovely nurse sort of looked at me and she said, "Oh, I think we've got some of those somewhere, possibly in ICU, I'll go and have a look." So my introduction to paediatric services was to start dealing with a child purely from a veterinary science point of view, where there was absolutely no information whatsoever apart what I could see in front of me. Anyhow, the child did well eventually, but things have changed, and now my junior staff are having hissy fits if the iStat's not immediately available, and the serum rhubarb and its allied minor things are not immediately in front of their faces. So things have changed for the better. The other early introduction that I think that really stands out a bit, like Deb was talking about, as one of those moments in your life where you never forget, was about 6 months into my training, and the hospital I was working at, we learned about Group B strep, and what we were seeing on a regular basis was these two groups of children that would get classical ARDS. When I say classical, they'd get worse for about 3 days, get a diuresis and start to improve, and we all thought ourselves pretty clever. And there was this other group that just got worse and worse and worse and then usually died. The really worrying thing about that second group was that they were quite often more mature infants, and often there was no good reason for them to die. Some of them were the products of insulin-dependent diabetes and some were sections, but it wasn't exclusive, but it was this great quandary as to how come we can get this sort of two populations and you couldn't predict which one was going to get worse and which one wasn't going to. And then my memory says it was George Mccann that published, but I'm not sure about that. And suddenly the light bulbs went off because we weren't using antibiotics as a matter of routine. Antibiotics were only used when somebody got really crook, and they never worked, or they rarely worked, because the kids were already past it by the time we had the bright idea to add antibiotic. And in those days, if we did use it, were these wonderful drugs called penicillin and kanamycin. And I don't know whether any of you here remember kanamycin, but it wasn't good for your kidneys and it wasn't good for your ears, and didn't work all that well. And then suddenly we had an answer, and the trigger in our instance was a child who'd been delivered at a caesarean section. I can't remember whether it was an urgent or an elective one, good size, good maturity, and about 6 hours of life was dead from overwhelming respiratory distress. And that child did get autopsied, and much to everyone's surprise, the lungs were full of hyaline membrane. And, this wasn't supposed to happen at this maturity. It wasn't supposed to be happening at all. And then here we were with this explanation in the form of Group B strep, and of course the rest is history now. And it was one of those moments, so suddenly, whenever the warning signs were there, ampicillin, gentamicin were thrown at these children, they stopped dying. And it was just, aren't we clever? And then you look backwards and think about the number of kids, a number of children who didn't make it through our ignorance, and also because of the reluctance to use antibiotics. So that was a pretty significant moment. And I'm intrigued now with the junior staff as they're coming through, because they don't know this story and they haven't seen the way we used to see these children die, and the rapidity with which they used to die, and the total inability to rescue them, and they don't have that fundamental knowledge, and they don't have that fundamental respect. And if I sort of say, I want you to start this child on antibiotic, they look at you and say, silly old fool, you just don't need antibiotic. What's going on about that, And you sort of try to explain that the fact the child's got a low blood sugar that's not getting better, it's not breathing all that well, and that funny little colour of yellow when it's only 12 hours of age, are not all good signs that this baby is doing well. In fact, you need to do something about it. So whether the wheel is returning and we're now going to have to see Group B strep kill people again before the light bulb flickers yet again is for the future to tell, I guess. But it was a very powerful moment.
Especially since we're not even testing for Group B strep anymore routinely in our maternal patients. We don't know what the risks these babies have now.
Yeah, that's right.
So, very interesting. So moving on to the panel, anyone else reflect those ideas or something else they've had?
I think moving on from the talk this morning on vaccination, I was an intern in 1983, so I went to the Children's in Melbourne in 1984. And for those of you who are much younger than me, every week we'd have a death from Haemophilus meningitis, and every week we'd have a child go home with deafness from Haemophilus. And we had epiglottitis, rife. And then Haemophilus vaccine came along and the world changed, literally overnight. The same thing sort of happened as happened with Group C strep. And then similarly with other diseases along the way. But Haemophilus for me in the mid-80s was something that took up a lot of our time. And incredible morbidity a lot of deaths, but a lot of children going home severely neurologically impaired from their meningitis and profoundly deaf. Some of it from the treatment, but mostly from the disease. And so the world has changed considerably. I think what I've watched, obviously, is that death is a much less frequent outcome. So I'm on the Consultative Council in Victoria, so we review all the deaths, and we get 7 or 8 sepsis deaths a year. But now we say, well, that's still way too many, but it's dramatically, obviously, better than it was. But it now gives everyone the opportunity to really focus much more around morbidity and patient experience, not just the pointy end, which is good. I just talk a bit about patient safety and how I got into patient safety. So in the early 90s, some of you remember that there was a study in New York looking at adverse events and harm in hospitals. Most of you were probably at kindergarten then, but anyway, I was a freshly minted consultant, and the paper came out and said, 20% of patients in hospital were having direct harm as a result of their healthcare, not as a result of their disease process. And that's 1 in 5, and it kind of got me thinking. And of course, at the time, though, we were sort of thinking, that's America and we're Australia and we've got a better healthcare system. Of course. And then the North Shore, Ross Wilson and his colleagues in the North Shore published a study there, and surprise, surprise, it was just as bad here. So we had a CEO called John DeCampo at the time at the Children's, who was a radiologist, but rather by training. And he was a pretty quirky guy, John, and you could sort of go to him with unusual ideas. And I said to him, why don't we start looking and seeing if we're doing this stuff here? Maybe we need to start picking up some rocks. And then he said, okay, you can have a session a week to pick up rocks. And then we started finding stuff, obviously. And for me, the tipping point came when very early on, so in that first few months, I was reviewing the record of a 13-year-old girl who had presented late on a Friday night as a direct admit to the ward against hospital policy, but emergency was busy. She was actually seen by an oncology fellow. She was a girl with AML, but she was in remission. She was on maintenance treatment. She was about 18 months in. She had still been a bit neutropenic, not a lot, and she presented basically with cough, fever, and some tachypnea. And her first set of obs on the ward were a beautiful picture of septic shock you've ever seen. So she had a roaring tachycardia, she was febrile, she had a pulse pressure of 130 on 40, and she was really unwell. But unfortunately, over the next 5 hours, despite her obs being tracked beautifully with her pulse pressure going like this and her heart rate going like this, and it just got missed. She was started on some oxygen, but she didn't get any antibiotics and fluids for a couple of hours. She didn't get any filler, and she died, and she had an E. coli septicemia. And I remember vividly just looking at her obs chart and thinking that these were experienced nurses and doctors on the oncology ward, and they'd all missed it. They were busy. There was a lot going on. There's a lot of background noise. We had an obs chart that was a piece of blank paper that didn't give them any clues that, in fact, this is a 13-year-old girl, so that, in fact, her heart rate at 130 was way too high, whereas, for a younger 3-year-old patient, that's not so... there were a whole lot of contextual reasons, but we just didn't get it. We didn't see the picture. And people said to me afterwards, well, you know, she might have died anyway. She was immunocompromised and she had a gram-negative sepsis, but we didn't give her a chance. We didn't give her the treatment that we knew could have turned the thing around. And I remember reading her chart and looking at that and saying, okay, we've got some work to do. And anyway, John gave me then 2 sessions, and we started the Patient Safety Committee in the mid-80s, basically to review the cases that we'd found when we started retrospectively looking back at records. And then, I mean, I get pretty excited now when I get told that in junior interviews to the registrars and the residents, they always get asked a quality and safety question. I go, oh, yes, we've made it. It's like, you know, people think about it now, so it's kind of been a lot of fun.
It's doing a full 360.
Done a full 360.
Excellent. Julie, do you have anything?
I've got a recollection. It's not a fine moment by me, but it certainly was a defining moment. And I was probably in maybe my second year of paediatric training, and I was just kind of getting into the zone and working out how to do this. And I had this little toddler who presented to the emergency department, and I was on for admitting, and I admitted him, and he'd had a couple of weeks of fever, and he had this funny sort of red rash on his hands and feet, and of course we'd lumbar punctured him and found a few white cells, but nothing much. And I was starting to get that little buzz of excitement because, you know, bugger the child, I wasn't really interested in the child, but I was about to make this awesome diagnosis of Kawasaki. Anyway, the more I sort of read about it, which wasn't so easy then because you had to race off to the library before closing time and get the journal out and read, the more convinced I was of this diagnosis. Anyway, the crunch came because we used to do quite formal presentations to our consultants, and my consultant at the time was a very revered paediatrician, Ray Tiernan, who some older people in the audience might know. Some, like me, might have been lucky enough to be examined by him in our fellowship exam. Anyway, he gave you these lovely benign smiles, but he was also called the smiling assassin, so you never really knew what the smile meant. Anyway, so I gave this, you know, pretty clumsy, halting description of the facts and why I thought it was the diagnosis, and he sort of smiled through his teeth, and we had to write in the notes in red pen what he quoted. And anyway, so he turned my fumbling words into this sort of lyrical, sort of eloquent, erudite description of the symptoms of, you know, multi-system, inflammatory, blah, blah, blah. And he said, I agree. He said, it's likely to be Kawasaki. And I said, yes. He said, what else could it be? And I was just floored, thinking, but it's Kawasaki. Anyway, so with his assistance, we came up with a differential diagnosis. The third differential was undetected chronic bacterial infection, and I thought, that's not a diagnosis. Anyway, didn't say it. And sure enough, the child ended up to have this form of meningococcemia that we see really rarely, which is just a grumbling kind of truce between the immune system of the child and the bug. And we did get it growing on about the third blood culture, but you know, the lab's never very happy with you when you give them a drop of blood to do a blood culture, and it wasn't until we sent them several mils that they found the bug. But it's interesting because what it taught me, which is I haven't ever forgotten, is the importance of making a diagnosis, which is not a one line on a page. It's a provisional diagnosis and a differential diagnosis. And in the days of, in the language of today, which is all about human factors and cognitive biases, that discipline of a differential diagnosis does away with a lot of those biases. Recency bias, it does away with anchoring, you know, getting stuck on the first thing that you came across. So I've held that close, and I think that's been really helpful.
Excellent. It's a lesson for us all, and one that I've actually committed recently too. Ian, would you like to add something?
Julie, you were lucky to have a library. I had smoke signals. My take's going to be slightly different. We've heard some interesting experience about medicine, and I've had similar things to all the other speakers, so I'm going to take a little behavioural turn here. When I was a registrar, that was in Christchurch, New Zealand, I had the good fortune to have C. Henry Kemp come to visit, who was the president of the American Academy of Paediatrics, who brought child protection into the current world. And what he did was two things for me. Well, my boss gave him to me to look after before his talk to us, and we're just Christchurch Hospital, nowhere special. And here was this little wizened old man who was shaking, white, sweating, and I thought, this is going to be the worst talk I have ever heard. And he started to speak, and he spoke gold. And lesson one, don't underestimate people. Secondly, the talk he gave was in monosyllables. There was no jargon of any kind. He spoke in simple English. And I've always, since then, tried to emulate that. If I'm going to be talking, I'm not going to use jargon. I'm not going to use abbreviations. I'm just going to speak simply. And I don't know if I've achieved that, but the best people I've ever heard always spoke like that. I also heard Linus Pauling speak when I was starting medical school. How long's he been dead? No, I'm not going into that. And he was a Nobel Prize winner in physics, as you know, and he spoke to us on the theory of relativity. And I would say that the entire audience completely understood the theory for the entire lecture and for at least 10 minutes afterwards. and he also used monosyllables. Mm-hmm. So this brings me to two aspects of C. Henry Kemp. He spoke to us, of course, about child protection matters. And his interest was really less about the fractures or the burns or whatever else, but about human behavior. And he tweaked an interest in me about human behavior. At that stage, I had, during undergraduate medicine, learnt nothing about human behavior, really. We'd done a little bit of stuff about Jung and Freud and Gestalt, and that was all very interesting, but nothing very practical on the ground. And then as I went into doing paediatric training, and went through, how many years did we do of that, whatever, still no training in behavioural medicine. Dare I say it, put your hands up if you've had any really good training in behavioural medicine when you did paediatrics. Okay, so he tweaked an interest in me in trying to find out something about human behaviour, because after all, who in which branch of medicine is not dealing with human behaviour? I mean, in our way that we look at, you're dealing with human behaviour all the time in assessing the way doctors behave. So why do people do the things they do? So he set me off on that direction, and I've been greatly inspired. That was my turning moment, the arrival of C. Henry Kemp.
Brilliant.
So he taught me not to underestimate people, that human behaviour was interesting, and please speak in monosyllables.
And as we well know, the behavioural aspects in paediatrics are huge. And
we're going to, there's going to be opportunity to talk a little bit about some of the methodologies we've developed. And after all, in doing regular medicine, you learned history taking, didn't you? You learned someone short of breath, bang, 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 you take a history, you know exactly how to do it. A mother arrives with an angry child. What history taking schema have we been taught? Yeah. What management schema have we been taught? You know, it's an area that really needs a lot of development. They're actually very interesting. When I got into this, the general attitude by me and by others was, oh God, behaviour. Please send me to someone who cares. Sorry, because I understand cystic fibrosis and diabetes and all that sort of stuff. I can handle that. But the behaviour things, and GPs are still saying, aren't they, behaviour? Oh, go and see someone. Teachers are saying, behaviour, go and see someone. Hang on, don't you learn behavioural management in pedagogics? Well, my daughter, one of my daughters, not Debbie, she's my niece, right? Get her straight. One of my daughters did both psychology and education. And at the end of that 6-year run, she said to me, you know, if I had a group of kids in front of me and I had to say to them, go into the classroom, and they said no, I still don't know what to do. And I thought that was pretty desperate, wasn't it? And I've been to 2 meetings in the last 12 months, one in Melbourne here about ADHD, one in Auckland, New Zealand, a general paediatric get-together in which ADHD was featuring. And do you know what? All the ADHD discussion, 100% was medication. There was not a single word about all the other strategies, behavioural, sensory, motor, home supports, all this kind of thing that we could do to look at children's behaviour. We'll talk more about that. But that's my angst.
As you can tell, he's passionate about this. And I think as an emergency physician, I'm a slight disappointment to him with my 10-second history-taking examination and move on. But to be honest, something that we do struggle with in emergency is behavioural aspects in children, and the ones that we find the most difficult to find a place for so that they can actually undergo the therapy they need. But let's move on. The next topic I'd like to cover is looking at the evolution of medicine, be it from ape to computer, God, our computer system, or what we've seen as things have changed. So what I'm looking for here is just what of what we've done has resulted in repercussion now to what we have to currently deal with as well. So looking at this evolution, Julie, you've probably got a fairly good insight. You've seen lots of sick kids over time.
I have, but I was contemplating having met up with Ian again and having recollected our association in Townsville when I was a first year resident. We were there, we weren't interns. Just the environment that I worked in. So my very first day on the job was in ICU, because that's what you did with first years in those days, you put them in ICU. Townsville in 1981 was an interesting place. There was no CT scanner, so the first patient on my first day I had to take to the angiography suite to do a 4-vessel angiogram to diagnose his extradural. Well, he'd coned by then. But fortunately we didn't know, because we weren't doing any invasive blood pressure monitoring or continuous ECG monitoring. But we were putting a finger on the pulse regularly. And when he'd finished in the x-ray room, he did look at his pupils, which were blown. But I learned to do a blood gas there with a glass syringe, and you'd crack open the ampoule of heparin, draw up the heparin in the glass syringe, stab the artery vertically, stick it in a bucket of ice, the syringe, and send it off to the lab. So the next thing I remember was being a paediatric registrar at the Royal Children's doing neonates. And I can remember some fascinating techniques. We used to intubate a great many babies, because of course we didn't have surfactant, so all the babies who were prem got hollow membrane disease and were ventilated. But for those of you with queasy stomachs, please leave the room now. The way we managed Meconium aspiration was that we would intubate the baby, we would put a piece of gauze, well known for its antibacterial and viral properties, over the end of the endotracheal tube, and as we pulled the tube out we would suck with our mouths on the tube. But we were really lucky because the gauze stopped all of the meconium germs coming through. And the only reason you spat into a bucket at the end was just to keep your mouth sort of clean. And you'd do that 5 or 6 times. But it did make you very good at intubating. The other very exciting advance then was we had a blood gas machine. So this was the province only of the doctor. And we learned how to put in arterial lines, and we did blood gases. They were in the old nursery at the women's, the gas machine was a floor above, and in the days before Fitbits, I could only guess at the number of stairs that I did, but it was considerable. And then the next huge advance I remember was going to Sydney, to Camperdown, where a very dramatic thing happened. They had one of the first oximeters. We certainly didn't have them in Brisbane at the time. And so we'd sort of overnight gone from guessing what colour the baby was to actually having a machine, which we didn't really trust, telling us what colour the baby was, so that was pretty exciting. And I also remember at the time doing invasive blood pressure monitoring for the first time on a liver transplant patient. So, they were pretty momentous times, and now we just shrug our shoulders and, look at all of those observations and imaging modalities. And I'm sure if I, continued, I'd think of a decreasingly useful number of interventions since then, but they were the major ones for me, CT scanning and probably oximetry.
Julie, when that percutaneous oxygen monitoring first came, did you think back, my goodness, all those children who were hypoxic we dealt with in the past and we thought they were all right?
Yes. No,
do you remember the duodenal capsules? We used to get duodenal biopsies for CDMs.
Oh, yes. That was a long time.
That was a long time ago, and that was really awful. So you had to get the children to swallow the capsules.
Crosby capsules, yeah.
The Crosby capsules.
Yeah.
And success rate wasn't great. And radiation was massive, because we had to screen them for hours and hours. It was terrible. It's hard to believe.
It's, I don't think I'm going to get beyond the meconium. And I'm actually quite happy that we've moved to a point where we don't even do our blind intubations anymore for that. And I must admit, also moving beyond to the pulse ox, where now we've got to keep those kids in who are bronchiolitis who SATs at 90, like turn the machine off.
I had an interesting experience skiing in Colorado and feeling quite unwell with a lot of vomiting, and we worked out that I probably had altitude sickness. And my husband rather reluctantly didn't go skiing with the rest of the crowd and caught a bus to the next village where the medical centre was and worked out how to navigate the journey. So he came back and got me, and I sort of hopped out of bed with my vomit bucket and got dressed and went out into the -20 and hopped on the bus and went to the next village. This is Copper Mountain, which is about 12,500 feet. And I was sitting on, you navigate the front desk in the US, which is, just making sure you can pay, and then finally get into a room and you find a nurse. She's taking a lovely history, and she was looking at me and she said, "No, don't you move, I'm just going to pop out for a moment." She came back, she said, "No, I'm just going to put this little peg on your finger," and we hadn't got as far as working out what I did for a living. Anyway, so she popped the oximeter on, we both had a look, and the SATs were 78%, and she said, "Now, don't you go anywhere, and I'm just going to be back in a minute." And she wheeled in a little bottle of oxygen and some prongs, and she popped the prongs on, and we watched it go zoop like that, and I stopped vomiting, and my headache went away. But I mean, I guess that's an example of something that we've known for at least the last 15 years in ICU, although it took us a while to work it out, which is that having low SATs is not the end of the world. SATs in the 80s are perfectly fine, and apparently SATs in the 70s are okay too, although you do vomit a lot.
Larry, you've had some interesting experiences with the advent of the retrieval system. To assist you with these very sick children who come to Coffs Harbour. What's been the change over time with that in the rural medicine?
Well, initially, retrieval was only if I managed to prick the consciences of the intensivists at the then Prince of Wales Children's Hospital or Camperdown Hospital, and it was literally a matter of negotiation because they would dispatch their own retrieval teams, and it was usually somewhere between 4 and 6 hours or even longer. And that thank heavens for Andrew Barry and the establishment of nets, because now it's only down to 4 hours. But it is significant because there are times when the weather is such that the aircraft simply can't get in. And the improvement in the type of aircraft that we have available to us and the helicopters has certainly made a huge difference. But getting a child ready for retrieval is interesting because it depends on how many you're retrieving as well. You know, you start off thinking you're going to retrieve one and you can multiply that, as happened to me on one occasion where I was assisting a obstetrician as he was delivering premature less than 30-week twins. And the first one came out and was in reasonable condition, but needed a bit of a kickstart, but responded, and then he had trouble extracting the second one, and we had an emergency dash 20 minutes from the labour suite up to the operating suite, where he delivered the second one and had trouble extracting the child out of the wound, and it was a very, very disinterested child. And while I was busily trying to get it to become interested, he said, "And here's your third twin."
That's right.
It was Sunday afternoon. I was by myself, and yes, getting the retrieval team interested was fascinating because that meant they had to send 3 teams. That meant 2 aircraft, and it was an exciting afternoon. Yeah. Good for your soul, good for your character, I'm told, but all I can say is thank heavens for the retrieval team because, you know, in days gone by it was... all I could think of was actually what it was like because there was a set of triplets delivered in Coffs Harbour before I started there as a consultant, and they were looked after locally, they didn't go away. And I can only imagine what it must have been like for the people looking after it. I know the outcome for those people, and sadly to say, the outcome for my triplets was no better, and related to really the circumstances of the antenatal stuff and the fact that this person just turned up on the doorstep on a Sunday afternoon and said, "Here I am. I've got twins." And the third one had got stuck right behind the second one, and so nobody could see it with ultrasound, and they couldn't hear it. And experienced people looking after it, but it was a pretty unnerving experience.
And did you have good staff to help you? Were the nursing staff, good
Oh,
at
yes,
bagging
yes,
so that
no.
you could go one to the other?
The nursing staff called in my colleague, because there were two of us at the time, and he came in, which one of the advantages, the arrangement we had is that we supported each other very well. And the anaesthetist for that particular delivery was a GP, but had a lot of experience with children. And he actually helped us while we sort of sorted through looking after this. Well, we had one ventilator in the nursery in those days. Mm-hmm. So it was like eeny, meeny, miny, mo, which one gets the ventilator.
Who do you love the best?
And monitoring, we ran out of monitors because we had the capacity to sort of really monitor only about 2 because that's all you needed in Coffs Harbour. Coffs Harbour's a quiet little backwater where nothing happens, except you get triplets. Needless to say, the nursery's better equipped now than it was, but hey, that's what rural medicine's all about, Ian.
Mm-hmm. So, Annie, rise of patient safety. What have you seen? What have you seen the changes that have occurred through this whole field being developed?
It's pretty interesting. I think in the 90s, there was probably 3 stages to it. In the 90s, I think I used the word patient safety because every time I mentioned the word quality or opportunity for improvement, I could see all my medical colleagues, just the blind went straight down and I lost them completely. And nurses had actually been very interested and involved in quality improvement way before then and had been very active in the space. So quality improvement was very much a nursing domain, and the real challenge was engaging medical staff. And I'm not sure that we've actually got there completely, but using the word patient safety sort of got people's attention, and talking about medical harm. And so a lot of the work in the 90s was just actually convincing people that it was actually not okay for these things to be happening. And potassium used to float around. You won't remember this, but potassium used to be in a container with red lettering on it, with sodium chloride in black, and they looked exactly the same. And there were many, many medications. I remember one of the surgeons once, instead of giving someone oily phenol for sclerosing some anal vessels, he used phenytoin, which isn't apparently quite a good sclerosant, because they just lined up next to each other. And we've still got instances where medications are, lined up next to each other. We had a conversation recently, again, for the 100th time about adrenaline and different, concentrations of adrenaline, and keep giving tenfold errors and so forth. So the sort of getting people's attention was sort of the main thing in the first 5 or so years. And there were a lot of critics. I mean, a lot of people, I never forget the day I went into a cardiac surgeon's office to say, can we just have a bit of a conversation about this case? And he just looked at me with horror in his eyes and said, what are you doing looking through the medical record of my patient? And, get out of here. And so it was kind of interesting to kind of engage people into the conversation. And then sort of the groundswell happened. I think that the Americans, Don Berwick, who's a paediatrician, and a guy called Lucian Leap, who's a paediatric surgeon, really got things going in the States in the early thousands, and formed an organisation called AHI, which many of you will have now heard about. And they really got very busy in terms of saying, 100,000 patients are dying in America every year as a result of medical harm, and it's not okay, and we've got to stop it. And so they really took it to a new level, which was fantastic. And then what's been most interesting over the last 5 years or so is people have actually realised that patient safety is not just about the patient, that there are the families, and obviously that's horrendous for them, but then very much around the staff. And I think that in hindsight, we absolutely didn't support the staff enough after something had happened. None of us go to work for things to go wrong, and they do go wrong. And if it didn't happen to you, then it was going to happen to me. And if it didn't happen to Julie, it was going to happen. It was, we had things so poorly set up that the accidents were all there waiting to happen. It took years before we actually locked away potassium. It took a long time before we didn't have bags of 50% dextrose on the wards. There was all sorts of things. It just made it so easy for people to make things go wrong. So I think that the staff support is something we so didn't get wrong, and I've watched people be terribly damaged after something's inadvertent go wrong. I know a gastroenterologist didn't work for 3 months after a liver bleed, and it's really, the impact is terrible. So I think we've got better at looking after staff when things go wrong. Things continue to go wrong, and we had a patient safety committee meeting at the hospital last week, and that will continue to happen. So I think looking after patients and looking after the families and looking after the staff is the thing that I think we've come to now, which is great. I think the other thing that's also become a nice and neat part of this is that people are now starting to focus on how important it is to actually go to work and have a joyful, there's a lot of discussion about the word, but to have a joyful workplace. And that going to work and being happy at work and being well supported and enjoying what you do is critical to actually the outcome of your care.
Do you mean we should train our bureaucrats in behavioural medicine?
I think that I do believe, I'm the eternal optimist, I do believe that in fact people now actually get that if you don't create a workplace culture that is focused on supporting staff, making sure that they're well looked after in terms of their mental health and their physical health, then you will continue to harm patients. But I think we've got there. We've still got some laggards, and I was in an ICU meeting not long ago, and to say that I was saddened by the behaviour of a senior clinician is understating it. So I think we've still got work to do, but I think there's been a lot of change. Undoubtedly, the really good thing is that mortality from harm has reduced. We still harm people, but we're not killing people in any way we used to do with potassium and intrathecal chemotherapy and all sorts of things that some of you will have heard of. So I think we've reduced the pointy end, but I think there's still a lot of harm that happens, and I think experiential harm is now something that we're becoming more interested in, and that's particularly prevalent in, of course, the emergency department, where the capacity to actually manage experiential harm is quite difficult.
Mm-hmm. Absolutely agreed, and I think a lot of our type A personalities don't help us forgive or forget those things that we don't do well. You focus on that, you dwell on that, and we do have to look after each other, and that's a very topical thing at the moment because we can all be lined up for that Swiss cheese, and it can happen to every one of us.
Yeah, absolutely.
So, Ian, shall I give you the floor for a little bit? I'll rope you in after a while.
Okay, well, when of course I will add, you just need a good pat on the bum, didn't you, when you did something wrong? So a good whack with a stick would usually fix it. That was the view. In saying that, what people didn't really talk about was all the good things they were doing that actually gave kids resilience. They just talked about giving a whack. So that as our knowledge of behavioural medicine came up, we were still finding parents saying, or indicating to other parents in the shopping centre that they just need to give their kid a good whack, didn't they? Mm. And parents often feel under this scrutiny from people about what to do. Some of the work done by C. Henry Kemp led to advances in understanding child behaviour. In Europe, smacking kids was banned in the 1990s, and everyone thought this will be a disaster. We'll have rat bags everywhere. But what they found was that the incidence of child injury and burns and emotional abuse actually dropped by saying that it's forbidden to do that. And it started to, I think everyone started to think then about what should we be doing? We've got these 65% of our outpatient referrals are now about behaviour learning problems. We in Ipswich have had 4,500 new referrals for behaviour in the last 6 years. This is, in other words, well beyond our capacity. So we have to be thinking, how can we push back a bit? How can we get better training for families? How can we get better training for teachers? How can we get GPs to do a bit more? And what are we going to teach them? So I alluded firstly that it's good to have a nice systematic way of doing an assessment or an interrogation. And this is a little bit how my understanding of the way I do things now, and it's a long way from mature yet, I think. I hope I'm still hang around long enough to get it that way. But so things sort of built up by layers. Little bits of understanding started to come through. Like, when you got the referral, please see this child with ADHD, and by the way, he doesn't wipe his bottom properly. You all know the answer, don't you? Empty his bowels out and he's fine. That kid's got chronic constipation with overflow, and as soon as you empty him, he's comfortable. So there's lesson one. There are medical things that alter children's behaviour. Now let's look at the common things, constipation, ear infections, not sleeping at night, maybe because of obstructive sleep apnea, maybe because of chaotic families, maybe because of stress. Let's just get a good medical history first, and let's pin their bat ears back too, as I did my daughters, I have to say, okay? Because things like dysmorphisms can be very significant for children in the classroom, being the wrong colour, the wrong size, having the wrong shaped nose. These children see those things as significant. Of course, in the medical things, you might be thinking of genetics and all the studies on these different disorders that we're now naming kids by. You can't be Fred anymore, you've got to be that kid with ADHD, haven't you? Which is an absolute disaster, okay? Renaming kids by a disorder. So, just as an aside, that brings on what we are now calling the serious reputation disorder. Look out for Julie, she'll hit you as soon as look at you, and Julie goes that, scratches her head, and like, oh yeah, it's true, yeah, she's going to do that. And we see this kind of process all the time, but that kind of serious reputation is so easy to get when you label children, give them a disordered name, then they can't grow out of it. Teachers chat to each other, watch out. What's that teacher going to be looking out for? Trouble. If you look for trouble, you'll find it. By finding it, you draw attention to it, you reinforce it, you make it self-fulfilling. So the child then starts to believe it themselves. That positive affirmation bias, if you want to use some jargon, I'm not into jargon, serious reputation disorder sounds great to me. Okay? So anyway, this understanding that there's this big bulk of medical things that I'm actually should be reasonably good at doing. Let's take a good medical history first and just see if we can't find something there. And then it started to occur to me, because therapists kept telling me, these speech therapists would come and say, do you realise that he's getting angry because he's simply not effective in his communication? People aren't giving him space to talk or space to think, and kids are getting suspended by that all the time. Just that simple thing, Julie, what was the idea of doing that, Julie? Now, what have I done? I've just completely blocked her thinking, haven't I? She's not able to think, so she's going to say, I didn't. And then I say back to you, you did, I saw you. And then you say, well, why did you ask me if you saw me? Don't get smart with me. She kicks me in the shins and I suspend her. Now, that happens every day of the week in a school near you. Okay, and just not understanding the space people need to think, especially if they have communication difficulties of one kind or another. They may have it because of intellectual impairment or because of a speech disorder. So these speech pathologists came to me and said, are you sure, you've got the right end of the stick here? So eye contact is a very powerful thing. Now, if I want to give Julie an order, I'll come to her face up, and Julie, I won't let her think, because otherwise she won't listen to what I'm saying, will she? Tidy your room now, And Julie's almost ready to rush off and do it. Are you? Yeah.
It's already tidy.
Just how to use communication to get more effective responses, because you can destroy people just by not understanding. Give the child time to respond. Otherwise, they just blurt out the first thing comes into their head. We call it the blah response, So the 2-year-old falls on the ground. The 6-year-old says, do it yourself. The 10-year-old swears at you, or maybe throws something around, or throws a chair around, Just these initial responses, because you're not giving people room to think. And you've all done it with your kids, haven't you, in the supermarket? They've said, I want that sweet. You just keep on shopping, walk down the aisle, leave them having a tantrum on the floor, and after a couple of minutes they say, that was a waste of time, wasn't it? And off they come. Whereas if you'd had a tantrum and hit them or something like that, then it just would have all escalated mightily. Lessons for emergency. Yeah. So, and how you use eye contact, how you use touch. So that was the speech pathologist saying, make sure, and of course within that came social communication. That was the next little layer that added onto it. So if I'm talking to Julie like this and she can't read my body language or get the sense of what I'm saying, it's very hard to get the full meaning about what we're talking about. So if I'm talking to someone on the computer, I lack the same information. I lack the nuances of their language. I lack their smell. I lack their touch. I lack the way their body's moving. So we're seeing a whole echelon of children coming up now who are not learning effective social communication. So they're coming along to us, and GPs are saying, please see this child with autism. No, he just hasn't learned to play. Simple as that. And there are children with autism, of course. But So understanding, social communication, how do we help children? Well, you can only learn it through play, by playing with your parents, by playing with your friends, by playing with the neighbours' kids, and squabbling with them. My kids keep fighting, Is anyone dying yet? No, well, let them about it. Because that's how you learn to deal with conflict, isn't it? By squabbling with your brothers and sisters. You all did that, didn't you? Yeah, that's how you learned how to deal with conflict. If someone tries to block it and interfere with it, you won't learn that task. Just like boredom is the onset of creativity, isn't it? For me, it wasn't. If we complained of boredom, then we had a job. But actually, if you let people be bored, give them a bit of space, so their brain's not fully occupied with something like their iPhone or their electronics all the time, then there's actually space for them to think something up. What could I do with these sticks? What could I do with this pile of mud? So children learn to be creative. So these play things really matter in all the children we're seeing now. A lot of these families aren't playing with their kids or letting them do this kind of thing. So we have a real job to try and teach that. Of course, then the OTs came along and said, do you realise that this child can't stand his socks? And that's the reason he's throwing things around the classroom. We said, don't be ridiculous, until I found a kid who was doing exactly that. We took his socks off and he was absolutely A1. People have been going to give him risperidone. We just took his socks off. Okay? So kids who need to sit under a desk when they're spaced out. And if any of you've read Babette Rothschild's stuff about a post-traumatic stress disorder, she's driven up this beautiful graph of how humans' emotions can be read. Their body signals are there in their pulse, their colour, their blood pressure, all these signals that should warn us, leave that child alone. So when a child sits under the desk in school and a teacher says, you sit up there and do your work, then that child is not in a mode. They're already reached a level 6 out of 7. They're not going to be able to listen. All they're going to do is create trouble. They're not going to learn. So smart answer, leave it be. Now, an OT called Sue Ellis has put a lot of this stuff online. It's free access. She's got about 107 different sensory signals and what you might do about it. When I first came across this, it blew my mind away. And we've seen plenty of kids just by looking at the sensory classroom, looking at how their sensory systems are supported at home, how that might be resolved. And that's a lot of ADHD. It's a sensory disorder, isn't it? There's an over-awareness of sensory signals coming into you. You can't suppress them. And on the other hand, there's other signals you can't pick up. A sensory disorder, if you like. Okay. So, and then they said, well, actually, it's more than that, being an occupational therapist. There's a problem with their motor, their fine motor. They're klutzers. They can't hold a pencil right. And these are these low-tone, hypermobile kids, often with a bit of speech delay, who can't write. And they're fine in the first couple of years of school because there's no pressure on writing, is there? And then suddenly there's this pressure, and they start throwing chairs around because they're angry because they can't get down their thoughts. So the OT said, well, why don't you let them talk to it? Why don't you let them put a few pictures together? Why don't you, give them some other way to get their information out? Use a keyboard, something else. So we started thinking about that, just like with sensory things. He needs to move. Well, you sit still, don't move. So you're going, and you can't hear a word the teacher says because you're focused on sitting still. That's not the answer, is it? The answer is solve it, don't block it. So let's give them move and sit cushion. Let's put a lap weight on. Let's give them a rubber band between the legs of the chair to push against. Maybe a squeeze device. So I've got problems with that. It's also a missile, isn't it? But So the OTs were telling us there are sensory things, there are fine motor things. The physios were telling us that these children who are so hopeless with their body movements, they get into trouble because they can't join in a game. Other kids exclude them. They get angry, and they're angry with themselves as well. So there's ways to deal with that. Curiously, that improved handwriting. Wonderful study from South Australia in the late 1980s, where they deliberately got back to doing PE, and the kids' handwriting improved. Madeline Portwood, who's written this great book called Dyspraxia, she's a GO in UK, showed exactly the same. Regular physical exercise improves handwriting. Could it be that simple? So instead of people getting angry, we're trying to solve it. So then we move on to learning. Are children getting the learning that's appropriate to their needs? Oh, they're not II, sorry, they can't have any support. That's crazy stuff, isn't it? I mean, people with a mild learning deficit, if we give them a lot of input, we're going to get a lot better value than if we give someone with a severe intellectual impairment support. Is this politically all right? Okay.
That's reasonable. I guess from all of what you've developed and the association you've had through the schooling, have you made an effect on those 4,500 referrals that you're getting through to Ipswich?
Well, what we've realised is that we can't deal with this. So what we started doing quite some years ago was we've got regular twice yearly meetings with education where guidance officers and heads of special education service, therapists, we all join together and think about all these motor, these sensory, these psychological things, and that's been very valuable. So that's reduced the impact a bit. We can now say to a school, no, would you do that? And they will. We've also got a standardised way of getting the schools to report, and that's helped us deal with the problem. So yes, we are doing better. Just recently, we've really started to get a bit sort of autistic about electronics and kids. No electronics, whatever, during the school week, Sunday afternoon through to Friday afternoon. And the parents that have done it, and I've been absolutely astonished at the number who have done it. And Ipswich isn't a place where you might expect that. Okay, and they're coming back saying, it's absolutely wonderful. My child's not angry anymore. We're playing games together. The whole family's functioning. Because part of the deal is you have meals together. Because that's where you hear your moral compass, isn't it? Where did you hear about the ethics of the community? Did you hear it from your parents? Did you hear it from a church or religious institution? Did you hear it from your teachers? Where do kids get it now? From the internet? Dad's on war games, mum's on Facebook, the child's learning ethics.
Annie,
No, I was just going to say, I think we've sort of all talked about the 90s as being a decade of ADHD and the noughties as being the decade of ASD and this being the decade of anxiety. And I think we're all seeing a really challenging rise in the number of primary school age children who are really very crippled by anxiety. And there are obviously many factors for that, but I think we've created a generation of anxious kids because we've got a generation of highly anxious parents. And parents now have got access to huge amounts of information, huge expectations on themselves in terms of what should be happening, and a very sort of, I think, a very demanding sense of what parents should be able to do, and it's kind of crippled parents. And I'm sure you've all seen it. I'm sort of amazed now. I get these kids at lesson 1 who can open up their parents' phone and open up a game on their parents' phone without there kind of being any limit setting to that at all. And but I think that when they take the phone away and the child throws a tantrum, they just give the phone straight back again. And so I think that we've created very anxious parents who are creating very anxious children, and I think there's a real societal issue now that...
That's also part of the fact that we just don't understand that the whole idea of a tantrum is just to make someone change their mind. It's just a game. And, if you refuse the game, then the child will be fine.
It's okay.
Provided you stick to your guns.
Yeah.
If you give in, then the child learns tantruming is the way I get things. There's also another behaviour related to that you may or not be aware of. It's called switching. I say to Julie, lovely drawing you've done there, and she says, no, it's rubbish, and throws it on the ground. And I then reassure her. In doing so, automatically reinforcing her notion that she's a failure. So when people move into people putting themselves down in that way, you're actually reinforcing their idea that they're a failure. That's called switching. And people of low self-esteem do it. People on the autism spectrum do it. We all do it a little bit. And for the most part, when we're resilient, it doesn't matter. But for our children who are struggling, it's really important to stay out of that zone. Just keep looking for what's right. Just keep looking for talking, giving the reasons. So there's been some press, for example, hasn't there, about we mustn't praise kids all the time. That's really bad for them.
The entitled children. Yeah.
What a load of nonsense.
Yeah.
The word should be, we have to praise children appropriately. We don't say something, awesome, awesome, when a child's just done something. No, it's not awesome. Got to be truthful.
Yeah.
Got to make clear expectations. Sorry, I'm rabbiting on.
And allow them to lose. As my husband would know, I like playing games of with my 6-year-old and letting him lose repeatedly. Makes me feel good too.
So in our service, we've developed a large number of resources, written resources, putting online resources and things for GPs and teachers and to some degree parents along these ideas we're just talking about.
Lars, do you find you have much support in Coffs Harbour with dealing with these children with behavioural problems?
No.
How do you go?
Well, I think this is a really good example of how the practice of paediatrics has changed substantially. I'm an organically trained doctor, and my total training in psychiatric or emotional issues was 6 months before I graduated as a fellow.
You were lucky, I got 3.
You were lucky, I got none.
And so I'm not a qualified, experienced or capable behaviour management person. And as the ADHD diagnostic epidemic took off during the late 80s and 90s, we have become quasi-psychiatrists because the area in which I work is not a wealthy area, and access to public resources is extremely limited. And we have had experiences where if we wanted a child psychiatrist who periodically would visit the place, if I as a paediatrician asked for a paediatric psychiatric consult, a triage nurse would determine whether or not the psychiatrist should see my patient. So we immediately started to run into bureaucratic issues because of the way the mental health system, I'd like to say functions, but I think the best word is dysfunctions. And there simply aren't the resources, like, you know, and you're talking about how with appropriate dealings with parents and encouraging them to manage their children, you can get great results without pills. In my area, we can't get those services, and the parents have an expectation that we will provide the pills because the teachers or the class or the school or whoever it was has said, go and see the paediatrician so you can get the pills.
And don't come back to school until you have.
That's right. Well, many a parent was told that unless the child was on the pills, they couldn't come to school. Totally illegal. But they were told that.
I presume, like me, you've written back to the headmaster saying, so you can prescribe them then?
Well, perhaps best not go into how that was managed, but it was, you know, there was this societal approach to this problem which was all pharmaceutical. And initially, in the early days, during the 80s and 90s, there was huge resistance from the education, the teachers, about this diagnosis of ADHD. It was just bad children, bad parents, and, you know, they needed a good kick up the tail end and you'd fix all this nonsense these stupid paediatricians handing out. Drugs, you know, who do they think they are? That's just nonsense. And I'd say within 5 to 10 years, if we said this child doesn't need a pill, then all hell broke loose. You know, instantaneously, when I say instantaneously, over 10 years, instantaneously, the expertise within the non-medical community on this topic had become overpowering. So the person who had the least say in the management of these children was a paediatrician. And the only way we could deal with a lot of these problems was by writing the prescriptions. So that this untrained psychiatrist is now fiddling around with powerful neuroactive substances, pretending he knows what he's talking about, when in fact he doesn't know what he's talking about, and who would much rather be dealing with status asthmatic or status epilepticus or a child with respiratory distress syndrome than these things that because I can deal with those, I can manage those, I can treat those. Whereas this other thing, I can't treat, I can't manage, and you don't succeed, hate it.
It's worse than that. These children are 65% of our outpatient referrals.
That's right.
It's not
They are now.
This is the new morbidity.
Yeah.
We have to know this stuff. We've got to change training for paediatricians, for general practitioners, and for teachers. We went back through the training programs. We've had a look at all that, going back through what university training programs teachers have had, what doctors have had. true behavioural medicine, I don't mean learning the kids' milestones. That's not behavioural medicine. And learning about the psychology, behaviours, and so on, how do memory work, how do all these different things we've been alluding to work. Virtually nothing.
Of the clinical practice guidelines, the mental state examination, so the Victorian clinical practice guidelines through RCH, mental state examination has always been, since time immemorial, the greatest number of hits, well in exceed of number 2. So it's actually just been rewritten for those of you who want to go and have a look at it. But, emergency departments are full of, kids who are, acutely distressed and because there is, the access to services is so poor.
Well, one of the many disturbing things about modern paediatrics that I see is kids admitted onto the ward and they will be on 3 or 4 different psychoactive substances. And many of these substances are being prescribed off licence. It says like the atypical, what do you call them, antipsychotic things, supposedly you can't prescribe them for kids under 12 unless they meet very specific criteria. And yet I would see 8-year-olds, 6-year-olds, 10-year-olds being prescribed this. I don't know how they're getting it.
4-year-olds we see.
I haven't seen a 4-year-old yet, but certainly seen 6-year-olds. But that was only one drug. There'd be fluoxetine in there as well, or there'd be amitriptyline, or there'd be
Clonidine.
a whole string of things I can't even remember, Lovan or whatever it is, things I don't understand very much.
This is a place for you, isn't it?
But
This is a place where
to
governance
see
is
children on a combination of these stuff, and their nervous system has still not developed. So what's happening to their nervous systems? And yet it's standard practice, you see. And if God help you, if you've got a child in the juvenile justice system, because those kids will be medicated to the eyeballs to keep them quiet and keep them sedated.
I see this as being very, very poor medicine at the moment. We're practicing a very inferior standard of medicine in handling children with their behavioural disorders. After I'd been to those 2 conferences about ADHD, I sat down with a couple of therapists and we just wrote down what would be the non-medication approach to ADHD, because people just saying, and the behavioural stuff. Well, what is the behavioural stuff? We sat down and wrote down a pile of stuff. We hit 25 different significant different things that you could be doing other than prescribing medication, but no one talks about it.
I heard someone say once to a group of young doctors that we are practicing, of what we practice, about 50% is wrong. The trouble is we don't know which 50%. And I was just thinking, sorry to take it back to boring acute medicine, but I was just reflecting on the mistake we made with steroids and croup. So those of us with memories long enough, steroids used to be great for croup. And in my first years of being a paediatric trainee, we used them all the time. And then steroids were shown to have no effect whatsoever in croup, so that we stopped using them, to the point where when I wrote up a project for my college, a Mayfair ACP, at Camperdown, I managed to find 100 cases of croup that was intubated, including 3 children who had to have tracheostomies, because we stopped giving steroids for croup. And then in the early 90s, we started giving steroids for croup. And, I really struggled to think of the last time I saw a child intubated for croup. Probably would be 1 every 10 years, yet we had 100 in a couple of years. It's just an example of sort of a created epidemic based on, we did that. I mean, people were, I think, doing the best they could with what information they had, but it just makes me wonder what mistakes
Well, I think you also mentioned earlier, we
these.
were talking about the use of PPIs. And, as a paediatrician in the community, I'm stopping them constantly, but the pressure on GPs and the pressure from maternal child health nurses,
Just the big epidemiological studies in the US to show that there's the all-cause mortality of people on PPIs is higher than anyone else. And this isn't a sort of a case control study where you need to look at confoundings. This is just all-cause mortality. But it's what we don't know. It's probably having an effect on the microbiota, rather like potentially these neuroactive drugs are having an effect on the developing nervous system. But we had lots of epidemics. We had an epidemic of drowning in Queensland that was well known, but I vividly recall being the fellow in PICU in Camperdown and ringing up my boss, John Gillis, on a Saturday afternoon saying, we're just getting 2 children in with drowning. And then I rang him up a couple of hours later and I said, we're just getting 2 kids in with drowning. And he said, yeah, you told me about them a couple of hours ago. And I said, no, this is another 2. And one of those children survived and the other 3 died. And, that's been a quiet revolution. We do get children who drown, but nowhere near the numbers. And motor vehicle accidents is another one where, we certainly see children with major trauma, but just
Nothing like it.
Nothing like it.
Pre-seatbelt,
I can't remember the last time I saw a major burn over 50%, and yet in the first 20 years of my PICU practice, we would, because they would come in and spend 3 or 4 months with us, you would count the times when there wasn't a major burn in the ICU rather than times that there was, and just sort of quietly behind the background, we've had a revolution in big public preventive programs that sort of mimic vaccines, I think, in a way, except they're not vaccines, but they've been equally effective.
Sort of thing.
I also wrote up just reminded me, just my other project was on bacterial meningitis, and yes, again, I managed to find, within I think 5 years, a massive case series. We were looking at exploring the effect of lumbar puncture in meningitis, and ineptly, in a retrospective case series, trying to show some sort of association with lumbar puncture and deterioration. And in these days, in those days it was sort of, you think they've got meningitis, do a lumbar puncture and then we'll have a conversation. And now it's, you think they've got meningitis,
Treat them.
give them antibiotics and then we'll have a conversation.
Yeah.
It's turned on its head.
One of the things that really inspires me is that we are able to have a conversation like this. We are reviewing what we do, we are auditing what we do. We're not like snake oil salesmen, who only got one way, it must always be done like that. And, I think CPAP was one of the things that's intrigued me in the last few years. We used to believe CPAP caused pneumothorax in neonates, now we use it to treat neonates with a pneumothorax. So our idea of what these things do keeps changing. So the one thing that really inspires me is that we can keep changing. We can keep looking at what we're doing. We can make it better. I think it's very inspiring.
Then we start getting to the sort of pointy end of the stick where we have all these children that we've kept alive who had some terrible neonatal trauma from just being born prematurely and somewhere else, and then they come back and they stay alive and they're part of our clinics and they come back to ICU because they are quite sick patients. What's your experience with these ones? It's becoming a larger cohort. You've got 65% behavioural and 35% chronic long-term diseases, with a few little smatterings of constipation amongst it. And it's another epidemic. And Julie, you'd see a lot of this in intensive care, wouldn't you?
Yes, we do. I mean, the whole population has changed. But I don't think it's for the worse. I mean, I guess my early years in intensive care was most influenced by the children who died. And we'd have somewhere between 50 and 80 children a year die in our ICU, and I did the first 15 years on a 1 in 2 roster. So I basically saw all of those children. So you do develop a very sort of intimate understanding about what death looks like. And I don't think I'd trade that for what we've got now.
No, absolutely.
Although it does give you a perspective that you otherwise don't have. But I think what I've learned is that you just have to leave your judgment and your values behind, and put yourself in the frame of the family and listen to them. I'm not suggesting, your words, Ian, moral compass. I'm not suggesting that you park that. But I mean, your values and your perspective have a small part in determining what happens with the family. And really, if that child is part of that family, it's really all about that child and that family. As long as you're convinced that there's not sort of undue suffering, I think it's incredibly judgmental to try and find a quick solution to something that the family's been living with for a long time. I think you have to be very respectful. I mean, from the outside, I have all sorts of terrible judgmental opinions about, what they're doing to the child and who's gaining from this. But I mean, people live their life to the best that they can, and I think you have to be respectful of that. And I think little by little, maintaining a positive engagement with them as they come back to the hospital repeatedly and come into ICU for various crises, you do eventually get a mutual understanding, and they guide you and you guide them towards this sort of path that's best for the child. I think the rise of palliative care as a specialty is fantastic,
Yes.
and I think it's a partnership between the acute team and the palliative team and the family. It's a three-way partnership, and I think that's sort of helping all of us navigate these new dilemmas that we didn't necessarily have once before. Certainly the old paternalistic approach of, we know best hasn't been around for most of my career, and certainly has disappeared now. And good that it has.
Thank goodness.
Mm.
Do you think there's just been a shift in that children who would not have survived now survive harmed, children who used to survive harm now survive intact? Is it just a shift, or is there a real a change in incidence and we just look after them better?
Well, mortality is dropping. There's absolutely no doubt about that. And revolutionary treatments come along that completely change the landscape, and there aren't many of them, but I think surfactant would be one.
ECMO?
Yes, I think ECMO is applicable to such a tiny proportion of the population. It doesn't make
the same impact.
Doesn't make a dent. Whereas we've pulled the survival of at the edge of viability for pretermers back from 26, 27 weeks when I was doing NICU to about 23 weeks now. And so I think, I guess in answer to your question, it has shifted towards survival, and I hope that it has shifted evenly so that the ones who used to survive damaged now survive with very little disability and a hope of a productive life. But I'm sure some of the ones who once would have died are now living with, all sorts of challenges that we need to be very clever at helping them with, seeing as we've helped to create that problem.
Well, in our last 10 minutes, I just want to touch on something which Meredith actually brought up this morning, talking about these vaccine preventable diseases, which I would say a lot of the younger audience are going to be fairly naive to, aside from whooping cough that we see a lot of, and now starting to get a few measles coming through. So our ability to recognise that even as an SMO in emergency comes to this child might have measles, I'm like, hey, what does that look like again? Right, let's go. It's a bit of a problem. I mean, you guys have lived through an era where you had epiglottitis, you've had this children's diphtheria, which I've never seen. Have you got some memorable cases of those?
I've never seen diphtheria.
I've never seen bubonic plague.
You sure?
It's been a wonderful change,
Yeah.
actually, just wonderful. But yes, I mean, we get kids now with scarlatina, scarlet fever, and our residents and registrars have never seen it, don't know what it is. It used to be very common. It's still not rare, but it's often not recognised. And so I guess Larry and I, maybe, I'm not sure about you guys as well, we're now the rash people in the hospital, we get sent photos on our phone,
I think group A strep's having a real resurgence.
I agree.
In all sorts of different ways.
Absolutely.
So I think scarlet fever is a good example.
Yeah.
I had a little child, that thing I was talking about before, the hubris with making a confident diagnosis and then discovering what a mistake you made. We had a little 3-month-old baby who came in with a hemoglobin of 16, which I thought, oh yeah, until I was reminded that the old units, that's the new units, and the old units would have been 1.6. Anyway, and they'd said there was a big liver and spleen, so I rang up my oncologist friends and said, well, why don't we bring the child in under you and we'll work it out from there. And an interesting child, for some reason he didn't look like he had leukemia, but we thought that's what it probably was. Anyway, sort of, did marrow, and there were blasts, but they weren't leukemic blasts, and we were puddling through this diagnosis over a day or two, and of course the child was in ICU because by this stage they were on sort of, respiratory support with a big heart because the anemia was quite low. And so someone did a torch screen, that old torch screen thing. Lab ringed up very excited because the baby's RPR was incredibly high.
Syphilis.
So then we had to test the parents and had a very difficult family meeting to explain why mum's seroconverted halfway through the pregnancy, because her early pregnancy syphilis testing was negative. And sadly, I think they were just a little too simple to understand what we were saying, so we didn't belabor the point. But that was the first case outside the neonatal period of congenital syphilis that I had seen. Although my colleagues tell me that the most common presentation of congenital syphilis these days is just with stillbirth. But still, syphilis is back. I mean, that's just ridiculous.
Well, tuberculosis coming back because we're multiply resistant tuberculosis.
Yeah.
Now, we haven't been really hit in Australia yet, but we will be.
But I think Haemophilus was an absolute game changer for me. I mean, it was just what we did every week in, week out in the 80s, for those of you who worked through the 80s. And,
It was true for me. It was every year there'd be 2 or 3 meningitis, but epiglottitis was 2 a penny.
Yeah, absolutely.
And
it wasn't a lot of fun doing those tubings, was it?
well,
Horrible things sitting there.
I had a wonderful experience in the end of 1976 with a child who was moribund, and an anaesthetist turned up with a Bird's apparatus and a racemic adrenaline, and in front of our eyes this child continued to live. A miracle. And as time went by, we got used to using adrenaline for these kids, and the racemic adrenaline came in a little brown bottle, and you used a number of drops, and it was very expensive. And it turned out that ordinary adrenaline, the other isomer, which is very, very cheap, is also very, very effective. But just after I being in Coffs Harbour by myself, and these kids had come out, and we had areas, hospitals that were 45 minutes away, 50 minutes away, and it was always 2 o'clock in the morning. I'd get a phone call to say, I've got this kid with epiglottitis. What do you want me to do? And basically, it was pray and do what you can. But with adrenaline, we had a treatment, and it was effective. And with the system that we developed, we didn't have to intubate, which was a major advance. But when hepatitis B vaccine came along, thank you.
It wasn't a mild change. It was like that.
Yeah.
It just stopped.
Revolution.
In 3 years,
Literally
it just
overnight,
went.
Yes. Yeah.
And it was, and it's the same. No, we had a child last week with a low bowel pneumonia. That's the first one I've seen for ages. We don't see these. So, and the pneumococcal pneumonia has just gone like that. No, they're still occurring.
I think we're slowly selecting for the other serotypes, personally.
But so if you're a vaccine antagonist and you had that experience, there's no way you could keep your position. It's just the introduction of vaccines. There's been nothing else, clean water, nothing else come in, just methamphetamine. I mean,
well, like Northern New South Wales, we had a collection of people who didn't like vaccines much during the 80s and 90s, and
Still there.
down further south, they're still around. And before the infamous MMR autism stuff, and measles immunisation was given as a separate entity, and there was a large number of unimmunised measles children in this particular geographic area, and then we had an epidemic, and the determined anti-vaxxers all decided to become determined vaxxers after they saw the first couple of real measles, because none of them had seen it, and then suddenly it was amongst their community, and they absolutely finished off our supply locally, and they had to fly in doses because this community came down banging on the door demanding vaccine, and we haven't had a problem with measles since.
Larry, the same thing happened in Townsville. We had, within the space of a fortnight, 2 adolescents came in with measles and both died, and something like 30,000 people came up in Townsville. Then the population was around 110. 30,000 people came in looking for vaccine. Many of them determined anti-vaxxers. So
That's happened.
and you'd love to say to them, wouldn't you? Well, but you couldn't. You're vaccinated. you're all right. Why are you leaving your child unvaccinated?
Yeah.
I was actually living in England. Did my last few years at Nottingham and in the early 90s. And, I think the Wakefield MMR stuff had an impact here, but it was 50-fold greater in England. And there were masses and masses of kids in the late 80s and early 90s who didn't get vaccinated, and we had a huge number of cases of pertussis coming through. So this is in the early 90s. And it took a long time for that tide to turn back in the UK. It's interesting that, one study and one vaccine and the impact that had on an enormous population. There was something like 7 or 8 million children that weren't vaccinated over that sort of 4 or 5 year period after the first publication. Before it obviously was all discredited eventually, but big impact.
Terrific.
It took quite a number of deaths within that for the vaccine program to be re-established.
We have 2 more minutes before the end. So I haven't had much participation from the audience. No one's thrown out any questions. Does anyone have any questions for the panel? It's a chance to ask whatever you want. Christine?
Hello, thank you very much. I'm Christine Smith. I'm one of the emergency paediatricians. I do have a question. I thought that this was really interesting array of experience. We all work in a field where we're constantly being thrown curveballs. So I working in medicine. I thought I'd look after kids and make them better, naively. We now look after children, as Ian has said, about parenting issues, behavioural issues. We now in emergency have children with alcohol and drug issues. We have homelessness. We're having refugee issues, health issues from refugee and other immigrant groups. We have also increasing research demands and all this information coming at us left, right and centre. We also are having problems with growing obesity, and these are all just in a network of emergency. My question to you guys is really with where you've seen such a change in the landscape, do you have any tips in a landscape which is constantly moving, IT being now overshadowing everything that we do, expanding uses of technology in our daily practices? Is there any ways that you guys can give us tips for navigating the changing landscape, or where you see this is going in the future, please?
I just have a bit of a reflection, Christine. When I'm confident here because I'm not the oldest one on the panel. I'm also not the youngest. Can we count, Deb? Anyway, but I remember when the internet came in, and I remembered when you didn't have to rush off to the library before it closed and looked at journals. And then you could get journals online, and then suddenly, there's rapid publication and, the PLOS journals where basically everything is out there straight away, and now you can just Google, you just about don't have to do a proper search anymore. And people used to say it would be the death of conferences, and once upon a time you had to go to every congress every year because that's where the breaking news came, because there was such a long cycle to publication. And I don't think that's been shown, and I think the rise of conferences like this and other conferences show the value in this connection. And maybe you don't have to have the sort of erudite scientific sort of, RCT presentations because they're all out there, but I think listening to people's experiences and networking and understanding, different practices in different settings is one way, I think, to try and keep abreast of a very rapidly changing situation. So it's unusual, I think, for me to go to a conference and not just pick up some amazing things that I hadn't even thought of before. And they're often not in that scientific area. They're more in the, different approaches.
Yeah.
And different experiences in different settings. So maybe that's something that can help.
Effective social communication.
Maybe it is.
Yeah.
Must have been all that playing I did as a child.
On that note, and a tribute to the Don't Forget the Bubbles team, I think we'll end this panel discussion. Thank you very much to my 4 panel members. I appreciate you spending the time and dredging through the archives of your memory for the experiences. And feel free if anyone wants to ask any questions in the breakout side to follow up with anything further. Thank you.